So the TRISST trial is a trial of surveillance in patients with stage 1 seminoma. And these are young men with a long life expectancy. And standard protocols require them to have multiple whole body CT scans, which have a significant radiation dose, and at least theoretically that may carry risk of health problems, particularly second cancers, going forward in the future. So we wanted to test whether or not we could either de-escalate the imaging schedule, going from a standard 7-scan schedule down to 3 scans, or to switch in MRI scans rather than CT scans. And there was, when we started the study, some concerns that MRI scans may be more difficult to read and might miss disease, so that was a rationale for doing the study. So we presented the primary results of the study at this meeting 2 years ago, and the actual primary paper's been published, which showed we met our non-inferiority targets. MRI scans actually had fewer events of high volume disease, which was the primary endpoint of the study. The 3-scan arm, there was some increase in the number of people with more advanced disease, but it didn't meet our pre-specified levels of a non-inferiority. So what we wanted to do in this study is, because MRI scans are more expensive and has an impact, we wanted to see how did this stack up in terms of health-related quality of life and cost effectiveness. So we've done a health-related quality of life study with help from our health economic colleagues, and we've inputted all the information for the patients based on NHS costs. And what we showed was that yes, the 7 MRI arm was the most expensive in terms of total costs. The cheapest actually was 7 CT arm, because of increased costs from the 3 CT arm with more relapses. And when we combine that with quality of life data, the 7 CT arm actually came out quite well. The 3 CT arm seemed to be worse in terms of being more expensive and not so good quality of life. And the 3 MRI arm had very similar outcomes to the 7 CT arm. So 3 MRIs had the same sort of health-related quality of life outcomes and the same and very similar costs. The 7 MRI arm showed that there was it slightly improved the health-related quality of life, but it was more expensive, and the incremental cost was about just under £8,000 per quality of life year gain. Our health regulator, health service governing body who says what we should treat, they usually have a cut-off of £20,000 per quality of life year gain as a cost-effective health intervention. So the 7 MRI arm would certainly meet within that. I should also add that in the original study there was no difference in survival in any of the groups of patients. So this is about what makes people better, and so we come to the conclusion that if we want to avoid using CT, which is what the thesis behind the study was, we could do 3 MRI scans with a very similar health-related quality of life and no real increase in cost. Or if you want to pay a bit more, you can possibly improve quality of life by detecting disease a bit earlier by doing 7 MRI scans. And I think either of those should now become potentially standard of care for this patient population.